Victoria Bird. Thank you so much, Victoria.
Thank you. Hi, and welcome everybody. I'm actually going to start by actually handing straight over to the first presentation. So we've got a packed afternoon, some really exciting talks from literally across the globe, and we can't say that very often, but from literally all different corners of the globe. So you don't want to hear me talking, so I'll pass over to Stefan, who's going to start by introducing the NIHR group and the reason we're here today.
Yeah, thank you very much. A warm welcome to all of you. Mental health, global mental health reversed is the title. What can we learn from others? Now, one thing we can learn is how to treat people properly. Because when I arrive at the airport from Lima, someone looks at my passport and then checks it for a few minutes. Maybe I have to fill in a form, then stamps, and that's it. When our colleague, an established researcher from Peru, wants to come here, he has to apply for a visa. Now, they said it would take 3 weeks. After 7 weeks, he hadn't received it. Sitting there every day with packed suitcases, waiting whether they could come or not. No, he couldn't. He wasn't the only one. Someone from Pakistan didn't get their visa either. So we can talk about equity and partnership and all that, but if that's the way how we treat people in such a humiliating, offensive, and degrading manner, then of course it's all hot air. So we are we are not those two presentations short, because Vicky Bird will step in for one, and Francisco Diaz from Peru has sent a film. But I think it is pretty embarrassing and shameful for someone like me who chairs this group to have to tell you that. So, is an acronym for an NIHR Global Health Research Group. The official title was Global Health Research Group for Developing Psychosocial Interventions at Barts and the London School of Medicine and Dentistry. It was funded by the NIHR, but also supported by Queen Mary and the Trust. The Trust was a formal partner in this group and invested a bit of exploring and advancing understandings of global mental health. We published a review paper about what global mental health can mean, a paper about the future scenarios for global mental health, and initially there were 20 copies of each paper for those of you who are interested in. Francois has some, so if you want to take that home. Building research capacity is something that we will not go into very much today. A very difficult subject, how to build research capacity with our money in other countries when there may not be the career pathways and not the structures. But today it is mainly about the third aim, improving care for patients with severe mental disorders, existing resources. What does that mean? We didn't want to go for specialized services with highly qualified psychologists or whatever. First, because the psychologists are not there. Secondly, even if the psychologists were there, the money is not there to pay for them. And thirdly, we want to use existing resources that are already there, in healthcare relationships, in families, and in communities. That means in relationships with healthcare professionals, we use Dialogue Plus. Most of you will know it. So very briefly, in a routine session with a clinician-patient session, patient and clinician fills this out, how satisfied the patient is with different areas of life. After that, has an overview and decide what they want to talk about, and then address each of the concerns in a four-step approach. Now, today is not the time to elaborate on that. Then with families, we had multi-family groups. So idea that clinicians meet with the families, but also patients, so that patients and families would share experience across their families, and with communities befriending, where people from the community, nothing to do with mental health, befriend a patient or a group of patients. We started with partners in Colombia, Bosnia, Herzegovina, and Uganda, and decided this would be our very, very ambitious goal, to have open non-controlled trials, exploratory or proof of concept, you could call them, with 30 patients in each of the countries on each of the interventions, putting in the applications that honestly we may not get every intervention, every country addressed. Then we start with visiting countries, not the worst way to start a project. So first Bosnia and Herzegovina, then we went to Uganda, to Colombia, and had a cheerful meeting in London, and with in good mood, we went about it. So we agreed on the interventions and the rough research design. We agreed that all interventions would be for 6 months, just to make them comparable, and that we would evaluate at baseline 6 months and after 12 months. So we had some consistency in key characteristics, but also some variability, and countries were free to change the implementation. But then something happened, some pandemic kicked in. No in-person meetings, very, very difficult recruitment of participants, no in-person interventions. So what happened to our wonderful, ambitious plans to do all these studies? This. So instead of open non-controlled trials, our partners who are sitting here managed to deliver RCTs, cluster RCTs, or individually randomized RCTs with large sample sizes, all studies completed, 9 studies completed, and with a much more methodologically ambitious and rigorous approach than we had originally planned. Then we widened the partnership. Some money was left, so we widened the partnership and brought partners from Peru, Argentina, and Pakistan in. And even they completed trials, open non-controlled trials with family involvement, Dialogue Plus, the only trial where patients were already recruited, and some had already been treated with Dialogue Plus in Peru. That had to be stopped. And if you know a bit about it, Peru was particularly hard hit by the pandemic, so that couldn't be completed. Then, admittedly with additional money, we also completed open non-controlled trials on using Dialogue Plus in primary care. We also had follow-on studies. So I mentioned research capacity. So we did manage to get out of this collaboration further grants, 2 about Dialogue Plus in Colombia, funded by the MRC and ESRC, a study on how arts organizations can work during the pandemic, funded by the NIHR, a large program funded by the MRC, and finally another one funded by the NIHR. And the biggest of all is still under embargo, so I can't share it. But there's even more. So we will present something from these studies. We also, that we did in Globe, we also have a few presentations on this year what came out. And one presentation, the last before the break, that was done even before we started Globe. But when you hear it, you will hopefully agree it's too good to miss. You should know about that. And that's where we are. And so I should pass on to Oneza from Pakistan, but again, she can only sit at home and watch us. And so Vicky Bird will step in, and then I pass on to you.
Thank you. So I'm going to be taking the role of Oneza in a minute to talk about the Pakistan study. But just before we go, just a few things, because I'm going to be chairing the rest of the afternoon. We'd like to make this as collaborative and as interactive as possible. So after each speaker, we'd ask if they've got any questions, any comments. We'd love to hear your thoughts. But we'd also remind you that we know we've got people online, and we like to think of this as a global, we're a global centre, we're a global research unit. So please, if you can tweet, make some noise on social media, because we really want this to be a celebration of the work that particularly our partners achieved in what was quite difficult circumstances. And just before I start, a few minor housekeeping rules. We're not expecting any fire alarms, so if you hear one, The exits are at the back and at the front. We're going to pause for a break around 3:30 and then come back to hear some other sort of presentations done by our group. And throughout the day, I will be housekeeping and hopefully doing some timekeeping. So if you see me wiggling a sign, this is mainly for the presenters. If you see me holding this up, it means you've got a minute. And if you sort of hear this you hear that noise, it means you've completely run out of time. And just to say, we've been learning about William Wallace. That's if they go over. So I'm going to start by general acknowledgements. All of our research was funded by the NIHR. As Stefan mentioned, we're part of a big global group. We've added the acknowledgements here so that we don't have to do that for each and every slide. But please just bear in mind that all of this work was funded as part of the NIHR group. On behalf of Anosa, who sadly couldn't be here today, what we're going to be talking about is a small-scale study that we did in Pakistan, particularly in Karachi, with our new partners, and how this led to an even bigger collaboration. So, although the group in general focuses on severe mental illness, we had some scope with some of the extra funding to focus on other areas of mental health care. And we know that in low and middle income countries in particular, common mental disorders are a big problem. Around 10% of the world suffer from common mental disorders such as depression and anxiety. But in low and middle income countries, that prevalence has been estimated to be around 20 to 40%. And we have estimates from Pakistan that particularly for women, up to 50% of the population may have some form of disorder. Yet 90% of people across the world, and particularly in low and middle income countries, have untreated common mental health disorders. And where care is provided, it may often be low quality or substandard. We know that the minimum level of care which people have called for often doesn't happen in many countries across the world. And part of this may be a resource issue. For example, in Pakistan, there are around 500 psychiatrists in the country for 220 million people. So if we take a look around this room at the moment, there's 100, 150 of us. So we've nearly got the entire population of Pakistani psychiatrists in one room. Just to bear in mind to say that again, for 220 million people. And overall, we may moan about our spend on the NHS and on mental health services, but in Pakistan, only 0.4% of the budget is spent on mental health. So this means that we need to look at alternative ways that we can treat and help people within the community and utilize some of the fantastic resources that we have. And one of those fantastic resources is the family. So we wanted to explore the use of trialogues, which bring together families and professionals and people with experience in mental health problems as a resource-low way and a resource-oriented approach that we could help people overcome mental health problems. So we did this in a very small open scale study. So it's around 40 patients. And we were particularly focused in an area called Karanji in Karachi. And that's an area which is low income and very urban. So it's in the center of the city. And we used trialogues, which involved bringing service users together with their carers, but also with sort of hosted by a mental health professional. But what's key in trialogue is that the sessions are co-produced. And I feel we use that word far too often. But here we mean that it was the families, it was the people with lived experience that say, no, today I want to talk about this. Next week, I want the session to focus on this because this is what I need. And people met monthly for about 6 months. So what did we find? In total, we had 29 people who had experience in mental health problems and 31 caregivers who regularly attended these 6 sessions. And these were in smaller groups of around 5 to 6 patients per group. And the results quite literally blew us away. We found that quality of life not only improved, but it improved on an effect size of a magnitude that we very, very rarely see in psychiatry anywhere in the world, an effect size of 2. And this is something that I want you to bear in mind when we hear the other presentations. So to answer the question, was this a one-off or is it something about low resource settings and resource-oriented interventions? But it wasn't just quality of life that's improved. We also had a substantial effect on symptoms measured by the Aga Khan University Anxiety and Depression Scale. Objective social situation improved, and caregiver burden. That was the only finding we found. Actually, caregiver burden didn't really change. So even though people found this intervention really helpful, carers still felt that there was a burden, but the burden was a different type of experience. So what did people say? So it's really interesting, some of the quotes that we got from some of our qualitative work, but people talk about how it changed the way they saw themselves and it changed the way they interacted with members of their family. So I'm not going to read these out, but I'll just leave them here for a little while. But just to pick up on a few points, that the idea of how people saw themselves as a crazy person and how that was changed by meeting other people with similar experiences, or how family members felt that it was actually a relief to be able to talk with other family members and to learn new skills. The second intervention that we looked at was Dialogue Plus, something that we know, particularly in East London, we're quite familiar with. So we wanted to see if this would work in primary care services for people with anxiety and depression. So again, we did an open control trial. So we had a number of primary healthcare clinics, and we recruited around 40 individuals who experienced anxiety and depression. Crucially, we used lay counsellors. So these are people used within services who do not come from a medical background, but receive minimal training in different types of interventions. So we trained people over 2 days. A number of colleagues from the UK and working with our colleagues in Pakistan trained researchers in a 2-day training event. And when we look at what was done over the 6 months, we found that on average in each session, 1 to 2 items were covered. And interestingly, we've done dialogue studies across the world, and it's always the same 3 areas that people want to discuss: mental health, physical health, and job situation. So what did we find? Again, it looks like the first result wasn't a fluke. We had massive effects on quality of life, a 1.6 effect size, massive effects on symptoms, and also our social situation improved. But the numbers don't speak loud enough. We also asked patients and staff members how they felt. And again, people found that it was a way that they could really come to see their progress, come to see different areas of their life. And it provided structure for the lay counsellors to be able to work with people with anxiety and depression. So I'm just going to leave this here. And just want to close by saying it was a really eye-opening experience to be working with lay counsellors, because out of everybody, the lay counsellors really felt that this could benefit people with anxiety and depression. They talked about how it gave them structure to be able to talk to people with only very minimal training, and they felt it could really, really have an impact on the lives of people. So we're currently taking this up further, and we're doing a large-scale cluster RCT in both India and Pakistan, where across both sites, we now have 420 people with psychosis that are going to be receiving Dialogue Plus, because we have such a will to work with the clinicians out there. People really, really want to have these interventions. So I'm hoping in about 2 years' time, I'm going to be standing up here with my colleagues from India and Pakistan, giving the results of the PIECES trial. But thank you ever so much. I'm going to quickly flip into the chair role and ask if we have any questions or comments. Yeah, please. So we've just had our conclusion, which we were going to come to in about 10 talks time. Yeah, no, I think that's right. I think part of the issue is that the lay counsellors and the services within Karachi at the time, they are very minimal. And these lay counsellors, they do speak with people with anxiety and depression, but at the moment the sort of provision is quite basic. So the idea of doing anything produces large effect sizes, but hopefully we'll be able to show that it's not just a case of novelty and attention, because we'll hear later on from some of our other studies where we've actually done randomized control trials where we've tried to account for some of that by having a slightly more active control. But I mean, these large effect sizes, I think it's obviously true that some of that is going to come down to the comparator, but we also take that alongside the qualitative and what people liked about the idea of empowerment, the idea of structure, the idea of actually being seen by the clinician as a person. All of these things we know we get when we interview people in the UK or in high-income countries about things like Dialogue Plus. It also points to the idea that if you get such a large effect size, we know there's not much happening already. Should we just be implementing? Do we need to be, am I going to get myself out of a job here? Do we need to be doing this research, or should we be going straight to implementing? And that's something that we hope to answer as the day goes on. I think time for one more question, then I'm going to hand over to our colleagues. I suppose some of the aim is to provide an evidence base to actually to show to policymakers. One of the things that we perhaps won't have time to get across here at the moment is how well linked our partners, our colleagues are within the countries with ministry members and people that make decisions and link in with policymakers. So it's about providing that evidence that actually these are low resource-oriented approaches. So the whole idea is that they shouldn't cost an awful lot of money. They make use of the existing resources, things that are already happening. But as we'll see, it's not true to say that they're completely cost neutral or they're completely free. There still has to be some investment. So we're trying to create an evidence base. More widely, it's also about sort of strengthening capacity in services by recognizing what people in the local community can bring to mental health care. And a number of our programs also focus on the idea of stigma and discrimination and how people with mental health services may be treated in the community. So it's all about awareness raising, but it's also about producing evidence. And when you're struck with such effect sizes, I think it then turns the question more to, okay, how much more evidence do we need? Now we need to think about implementation. Great. So I'm now going to hand over, and we're actually going to hear about a lot of the work that's been happening on the ground. So I'd like to, first of all, welcome up Professor Sagani Musisi, who is from Uganda. He's one of our senior researchers, and he's going to be telling you about a really fascinating study about volunteer support that we've been doing in Uganda.
Thank you, Vicky. That works. Good afternoon, ladies and gentlemen. I've been introduced. I work in Uganda at Makerere University, as a professor of psychiatry. So our involvement in this study was to look at how volunteer support intervention would help patients with severe mental illness in Uganda, and was a controlled pre and post study. Uganda, lies at the source of the River Nile, and that is the source of River Nile. With a new bridge that we have just built, one side is Lake Victoria, the other side is the river. That's the research team, which collaborated with people here, some of whom you can see, some of whom you will hear about. So, low and middle income countries, including Uganda, often have limited resources to provide specialized mental health care, especially for people with severe mental illness. For example, in Uganda, the psychiatrist to patient ratio is about, to population ratio is about 1 to 850,000, meaning that in a country of about 45 million people, we have about 50 psychiatrists. Somebody said this is all the psychiatrists in Pakistan. In Uganda, it is a third of what is here. So the study aimed to assess the feasibility, effectiveness, and acceptability of volunteer support community mental health care, meaning befriending for people with severe mental illness in the Ugandan context. And the severe mental illnesses we dealt with were bipolar disorder, schizophrenia, depression, epilepsy. Epilepsy is usually treated by psychiatrists in Uganda by patient preference. So as we said with the pilot efficacy control trial, which we found after evaluations, we had a study arm and a control arm. These figures of the proficient populations and the volunteers were actually designed to be like that. It was not through calculations. We carried out these activities every 2 weeks for 6 months, and we measured the outcomes, quality of life using that instrument called MANSA, objective social outcomes using the 6 scores, treatment adherence, symptom ratings, and stigma. So what are the kinds of volunteering activities that we did? We befriended this patient with SMI. So, for example, we interacted with them and in attending churches, in games, in outings, in visitings, and socializing. We reminded them to always take their medications and attend for their medication reviews. We encouraged them to participate in income-generating activities. You have to remember that in Uganda, there's no social welfare for people with any illness. You contracted a bad illness or some misfortune in your life, you're left alone. And people with SMI tend to be neglected, stigmatized, and really forgotten in society, almost outcasted. So the kind of income-generating activities they engaged in were things like candle making, liquid soap making, baking, shoe polish making, simple activities. And we also made sure that wherever they were referred to any medical intervention, that they went there. So what were our findings? These were the main disorders that we dealt with, common in both the control group and the study group. What were the results? The quality of life significantly changed in that arm of the study where volunteering took place at 6 months and at 12 months. But in the control arm where there was no intervention, there was really no change significantly at 6 months, and only minimal change delayed by 12 months. Secondary outcomes. For example, the objective social functioning. We found that both in the control arm and in the volunteer arm, there was really no major change, and we shall talk about that. But in terms of psychiatric symptoms, significant reduction in those who received befriending or volunteering at 6 months and 12 months. And in the control arm, actually the symptoms increased. And by 12 months, there was no change between baseline and the end. Stigma and medication adherence seemed not to change very much in the volunteer arm, but the stigma decreased in the control arm and increased medical adherence in the control arm. We wanted to know what actually happened to get those results, but we think it has to do with the effect size. Now, what about the feasibility, qualitatively, of this intervention? One, the program was enjoyable to the patients, as you see that quote by a male patient who said, I visited various places, I got new friends in life, the things I learned will help me if I put them into practice. Before, nobody could talk to somebody with schizophrenia walking on the streets in Kampala or in their villages. Volunteers seem to love and care for the patients. These were volunteers who had nothing to do with mental illness. They were part of, quote, the stigmatizing populace. And finally, they began to talk to these people. So one 20-year-old male volunteer said, my patients felt free to come to me. We had a pregnant patient, for example, who gave birth during the program. She visited us over phone. She invited us over phone to visit her home, and we took her gifts. Acceptability. Is it acceptable, this volunteer supporting intervention? The community of volunteers accepted the program. For example, this one said, I benefited from the program. The program had impact on my life and in my community. It's now easy for me to talk to other mental patients and to my parents nowadays. I can easily refer such patients to health facilities for management. Management in my community now or the community my community now knows that I can help them with their mental issues. What about the patients? Did they accept it? One patient said, 40 years old, I was happy in the volunteer program. I felt at peace because volunteers showed us love and took very good care of us. I no longer consider myself mentally ill. because of the good treatment I received. I remember in the past, whenever we were unwell, clinicians used to speak to us very rudely, but the volunteers treated us very well. Part of that is because these clinicians tend to be overwhelmed by numbers of patients with very little time. Was the program effective? Effectiveness of volunteer support intervention, purposeful reprogramming of life's routine. This 54-year-old single male patient doing voluntary support said this: I clean my compound and keep personal hygiene. The issue of moving from house to look for food stopped. I now discourage it. I can now cook. This is a patient saying how they benefited from the program. So what do we take home? Volunteer support intervention or befriending is a doable psychosocial intervention for SMI patients in Uganda. Community volunteers were able to work with the SMI patients effectively. Among the group activities include income generating activities, which kind of gave self-esteem and confidence to the patients. Befriending worked with our patients, and their participation were key in the patient care. However, working in Africa, working in Uganda, one wonders on how we can also involve alternative medicine providers, because many of our patients go to traditional healers and faith healers. Thank you very much.
Due to fantastic timekeeping, we have time for some questions. So if there's anyone who would like to start us off.
Very interesting question. We were actually talking about this thing in Uganda. We talked about it here a little bit of how we are going to convince already our Ministry of Health to kind of scale up this. We are getting results. We shall do some disseminations there. We shall talk to various people and we shall try it out. There's some other things that we also would like to add in. For example, how do you go to reach out to very far communities in rural areas, in post-conflict areas? And we have some ideas. We're already doing some other kind of research to try to back this one up. And actually we have involved Queen Mary in part of that research to see how we can scale up, how we provide this kind of service generally. But it enabled us to talk to our SMI patients. That's the key thing, these psychosocial interventions.
Thank you, that's very interesting.
We wanted to recruit volunteers who were not patients, were just in the community, but could be trained in what they were going to do. So many of them were not psychologists. We did not recruit anyone who had some kind of mental health training, but just ordinary students maybe, or people in the community, but who had some education to understand what was going on. Yes. So it was not sophisticated, like Stefan here said. Recruit ordinary people to begin to talk to people with mental illness and befriend them. There were 3 types of studies. There was volunteering, which is what I talked about, or befriending. The family groups, that's another study. Very interesting results, very similar, and there was dialogue. So in this one, this did not include, was not for families. It was just ordinary people in the community, befriending people with severe mental illness.
We've got time for one more question, say. I noticed that some of the quotes you use the word love from the volunteers.
Yeah.
Do you think it's to do with economic healthcare professionals? How do you think it change this healthcare professional?
Thank you very much for having picked that up. People with severe mental illness, getting a severe mental illness in a developing country where people are not very much aware of mental illness and its causes is like a curse. You get stigmatized and outcasting. People avoid you. They won't talk to you. They'll think, I think somebody talked about it, was it Stefan? They think you're going to be violent to them, you're going to hit them, you're going to commit suicide, they distance themselves from, even families do that. For the first time, the person with severe mental illness, somebody came and said, hello, Vicky, how are you? What are you doing this weekend? Can we go together? They felt love, and that was key. Thank you.
Just one more round of applause for Professor Sagani. And I'd like to introduce my next speaker, who's coming from Colombia. This is Dr. Felipe Bretiro Rodriguez, and he's going to be talking about one of the other arms of the NIHR group, which is about the multifamily group. So I'll pass over to Felipe.
Well, hi, I'm Felipe Bretiro Rodriguez from Colombia. I will tell you about our experience there. First, Bogota is the capital of my country, and there is in a valley. So here you can see Bogota. The next one here is our university, Javeriana University, and this is part of the team. Our city have a particularity, yes, the population. It has 7.8 million persons that it implies people, and it implies the 15% of the population of Colombia. Considering this, we have only one psychiatry per 100,000 people in our country. And all those psychiatrists are ubicated or localized on only most of the psychiatrists only on 5 cities on our country, considering that we have more or less 1,300 municipalities. Also, the communication between clinicians, patients, families is often challenging. It may be because of the heavy emotional burden of clinicians, patients, but also the emotional burden of the families of the caretakers. And I think that in medicine is in that way, not only in psychiatry. We can find that the relationship could be hierarchical. So it can be difficult for all the patients, all the participants. Now, the multifamily groups, it has been tested in different countries. It is based on a trial. And we have some rules or some characteristics, like groups are composed by clinicians, patients, and their families or friends. It recognizes the civil rights, the patients and the family strengths. It must be a mutual respect, and it should be a safe space for sharing experiences and for a mutual learning. Also, it is flexible, allowing for a local adaptation. Well, our implementation, we made 6 groups. Each group should meet monthly for a time of 6 months. And each session or each meeting should long from 70 to 19 minutes. They had or we gave them some refreshments and the travel expenses to facilitate the experience. It is important that to say that we could make all the sessions despite the difficulty on attendance. It means the traffic in Bogota is very difficult, mainly Saturday and Fridays that were the days that we used for these meetings. And for other characteristics. And previously, in each meeting, they talked about previously established topics that families and clinicians thought that were very important to talk. Well, in our quantitative results, we enrolled 30 patients, 15 female and 15 male, most of them with bipolar disorder, the blue one, and the age range was from 24 years old and 61 to 61 years old. Yep. About the family or friends, we enrolled 41 participants. Most of them were female, and we got 7 male. And the age range was broader from 24 to 85 years old. About our results or the outcomes, we saw or we found an improvement in all outcomes. That if you see, you can see that it's not statistically significant, but it maybe was for the small sample. Nevertheless, you can see a positive trend and an improvement of these means. Also, this intervention, family intervention, was already tested in another studies. So here our main aim was to test the feasibility of this intervention in our country. Okay, about the qualitative part, we interviewed 6 clinicians, 15 patients, and 10 family or friends. We got 4 main domains. First, the non-hierarchical relationships. We found a change here, and you can see in the code, the experience was pleasant because in some way you feel like the others. It was a space more comfortable for all participants, and it gave the opportunity to talk about many doubts, many topics that maybe in the normal consultation, patients don't used to talk about it. Another one is the collaboration between the participants, not only the patients, but the participants. You can see it helped me feel supported, listening to the more of the other patients. I identified with their experiences. It was very important to let them know that they are not alone. And that maybe is a thinking that patients, but mostly familiars of the patients, that could have in their heads. Another one is solutions in everyday life. Here is a point that covers different topics. For one side, in one hand, we found some practical things that we have to think when we are going to apply it in Colombia and another study. Yeah, but also it includes some topics like legal concerns and medication doubts. And finally, changes in we found changes in family dynamics. It is because families sometimes get out of the dynamic of the consultation. Now, our conclusions: multifamily groups are feasible and low cost. They can be beneficial for patients and their families. Also, they are an option to improve community mental health care approaches. However, we have to take into account practical aspects of implementation that are very important to facilitate attendance. And lastly, longer provision need to be tested in Colombia and in other countries, I think. Thank you.
We've got time for just 1 or 2 questions. So who would like to start us off?
Thank you for the presentation. And I was just wondering whether you would expect to find similar findings in rural areas, and especially those affected by armed conflict.
Well, I think yes. I think we have to test it, but I think yes, because families are everywhere. Yeah, our third aim was to improve the resource. So I think, yes, because families are in all everywhere, we include psychiatrists, but I think that is not necessary have to be a psychiatrist, the therapist. So we can use these resources. Even we can implement it we could implement it in a virtual way. So I think it could be a very good approach. It is feasible.
Thank you. So now I'd like to introduce Professor Alma Zuba-Kulnovic, who's going to be talking about some of the amazing work that's been happening in Bosnia and Herzegovina. Did I pronounce it right? Fantastic.
Thank you, Vicky, and thank all of you for sharing this afternoon with us. And yes, so far this afternoon, this is the fourth continent. So just to remind you of the power of this global exercise that we did with Stefan Priebe and his team. I will tell you a few things about the country and the city I come from, and I will give you an overall wrap-up of the research that we've done within this project. So yes, this is Sarajevo, the capital of Bosnia, a very beautiful city in the valley, surrounded by mountains, may I say Olympic mountains, because we have the Olympics, may not be so handy when you are besieged. And we were besieged in the longest siege of a city in the former 20th century between 1992 and 1994. So some things we are famous and infamous for. This is a Haggadah from 14th century, and Sarajevo has been able to keep it for all that time, even during the herbicide of the conflict in the 90s. Yeah, we are infamous for being the casus belli for the First World War, because the Archduke Ferdinand was assassinated in Sarajevo, and that started the war rolling. We are famous for the Winter Olympics in '84, and with the status of then Yugoslavia, we had the biggest attendance with both East, West, non-aligned, so nobody boycotted the games. We have the film festival, we have a Nobel Prize in Literature, and yes, we had an Oscar. So we tend to gloat on our multiculturality, because yes, Sarajevo physically is the place where you can see a mosque, a Catholic, an Orthodox church, and a synagogue within 300 meters. And not only once, you will see it in another neighborhood, replicated. What is left of multiculturality is very, well, in architecture, it still exists. Unfortunately, this is the library that was completely burned down in the last war. And this is the place where Haggadah was kept. Well, fortunately, it was saved, but many other manuscripts have burned. Today, we have the nationalist parties that are in power for 30 years. First, they like to be in power as all politicians. And second, they're extremely rich from being in power and they want to stay there. So they keep fueling nationalism. I don't know where it will lead us, but this is not only Bosnian problem right now. Now, the better part of the story, this is the Department of Psychiatry where we work. And this is the beginning of our team exercise with 3 junior researchers that were recruited and hired for this job. And each one of them has performed and completely performed a full package of an RCT. And yes, 20 years ago, I was a junior researcher with Stefan Priebe mentoring my PhD. So I hope we will keep the ball rolling, even when Stefan and I leave the scene. Definitely our 3 colleagues who have just finished their medical school have proved to be competent researchers in the course of this study. What did we do? We wanted to test the feasibility and effectiveness of 3 resource-oriented methods that are doable with existing resources through evidence-based randomized control trials. So we did Dialogue Plus that you heard about from Stefan, but this is the first trial in the world that tried Dialogue Plus, not with severe mental illness, but with anxiety and depression disorder, first published trial. Then we did volunteer befriending, and that was really volunteer befriending study for patients with serious mental health illness. Because we were not cooking and doing anything together. This was the encounter of equals, of people meeting each other and having conversation over coffee, cakes, theater, zoo, whatever, about life, not about the disease. So they kind of gave new content. And we had multifamily groups that are completely sustainable and doable for the future. All our interventions, we were very lucky to recruit very early, and we performed them before the pandemics, but and we had 6 and 12 months follow-up compared with the group with treatment as usual. Yes, for the follow-up, there were some things like doing the follow-up interviews in the parking lot, because during lockdown, the patients were not able to come into our service, but that was the charm of it. This is the training of clinicians, and these are our trials. So we did Dialogue with 72 patients, and just to summarize, we recorded with heroic effect sizes, that was your question above, increase in quality of life and symptom levels. In volunteer befriending and multifamily groups, these results were replicated, plus we had objective social situation improvement, which may have been hazardous, but then again, twice it happened in the experimental group, it didn't happen in the treatment as usual group. We have published our results, which is great. And what did we get? Well, first of all, we got to meet all these people who are presenting together, because we knew the people from UK before. We got to learn what it is to be a psychiatrist and to help people with mental health disorders in other cultural and geographical contexts. Yes, Bosnia has 1 psychiatrist in 10,000 inhabitants, but and that is getting better and better because our population is decreasing due to emigration. And COVID helped too. Lousy services helped too. Sorry. That's why I was angry, not laughing. So we have professionals with hands-on training to deliver those services. Might be difficult for volunteering, but the other 2 are completely doable in our apartment. We have young researchers who are trained and competent in research method, study implementation, data analysis, and scientific publishing. And they can go on and keep it rolling. And we have a functional international network, global network, it's not international, for further research and exchange. Thank you very much.
Thank you. And again, we have some time for some questions.
Between anxiety and depression, did you find any difference?
You may have noticed that the N was pretty small, so it would have no methodological soundness to subgroup patients. We didn't subanalyze. But you will hear later anxiety disorders from Argentina, and well, we may then talk about differences. It was too little. It was a cluster randomized trial. It would be ridiculous to compare. Perfect question. But I will leave the floor for Dr. Sikira, who is a young researcher, who will give you the perhaps the explanation how it works, because she will present qualitative research in all 3 RCPs. Sorry for not answering.
We've got a question over there.
all cultures work together to save it. And the real heroes there were the librarians. Am I right? They were the heroes saving this, not one of the manuscripts.
Yes, the librarians, and there was this something like with the George Clooney film. There was an artistic unit in the army. I don't know the name of the George Clooney movie. Sir?
I don't know how we're going to follow George Clooney, but over there.
There was a film about saving the arts in Italy. We tend to gloat on our multiculturalism, and we have the experience of ethnic cleansing. So it's a long thing. The multiculturalism is mostly a myth now, because ethnic cleansing has. You are familiar with this euphemism, nettoyage ethnique? Serbian part is Serb, Croatian is Croat, this is Muslim. So, but maybe young generations, maybe they will get sick of this, what we left to them, and maybe it will come back.
On that note, I'd like to thank Professor Alma again. And as already mentioned, we're now going to hand over to one of the researchers who worked on the project from Bosnia, Dr. Hannah Shakira, who's going to talk to us a little bit about the qualitative findings from the different RCTs. So welcome, Hannah.
Okay, thank you. Hello, everyone. There's so many of you here. Okay, so today I'm going to talk about our qualitative study. We published a paper with this title, Common Patient Experiences Across 3 Resource-Oriented Interventions for Severe Mental Illness, a qualitative study in low resource settings. So as you could hear from the previous presentations, quantitative data from all these 3 interventions showed very significant benefits for patients. It improved their quality of life, improved social functioning, and it decreased their symptoms of their underlying diseases. So here are the photos of the pictures of the papers. So after this, we of course we have to set a question how these excellent results actually happened. So we did a study with the question, do patients' experiences point to some common processes in these 3 interventions? So we did a semi-structured interviews with open ending with 45 patients with 15 patients from each of these interventions. All these patients were purposefully selected at the end of the interventions after the 6-month period, and they were picked based on their level of engagement and also based on their outcomes. So all these interviews were audio recorded, transcribed, and analyzed using the thematic analysis framework proposed by Brown and Clark. So after the analysis was done, we come to 3 broad themes that capture the overall experiences of the patient. So the first one was an increased confidence and agency in the treatment process. Second one was a new and unexpected experience in treatment. And the third one was concerns about the sustainability of the interventions. So in general, most patients like the new treatment option that address these psychosocial aspects. Many of them seem to appreciate the time to share their problems and to receive guidance and companionship. And also, we've got many valuable informations in these quotes on facilitators and on barriers for implementing the interventions. So on the next slides, you can see some of the quotes from our patients for these themes. So here are the quotes for this first theme, increased confidence and agency treatment process. So many patients reported how during this, throughout the studies and after the studies, they became more confident. And some of them told us that was due to gaining new skills and new skills and new habits to manage much better their condition. Also, they said that they felt more empowered to take active role in their treatment. Patients from Dialogue Plus actually told us that they think that it is due to structure and of the Dialogue Plus because of its characteristics and the solution-oriented approach, and it's very clear structure, which helps you actually to break down your problems in parts and to work on your problems step by step. Also, patients from the multifamily groups said this was due to very friendly atmosphere during the meetings, and that they felt much more equal to their clinicians than it was in their treatment as usual. So they said that this atmosphere gave them a chance to voice their opinions about their treatment. Also, here are the quotes for second team, a new and unexpected experience in treatment. So many of the patients, they had general affection for the treatment in these interviews, but in the beginning, it was even very hard to enroll them into the research because no one of our patients from our studies have never been before in the research before. So there was a much of initial skepticism about the research in general. So in these interviews, they tended to compare their expectations and their experiences, and they were very, very happy in the end, as you can see here. Okay, and we also got some informations that could help us to improve our intervention in the end. So when we ask them in the end if they are motivated to continue their interventions, most of them said yes. And it was mostly because of the good experience they have. It was also because they were genuinely happy about the relationships they made during the studies with their families, with friends, and also with volunteers. And when we were talking about obstacles, these were mostly some practical terms, practical things like, for example, patients from multifamily groups told us how they would prefer that these groups were held outside of the hospitals. And so that would not remind them of their treatment as usual and hospitalization. Also, they said us that they would be more happy if they agreed on one topic for the next session. So against that, for example, people in volunteer support study, they wanted to have more flexibility during their meetings. They didn't want some kind of strict agenda. Research from our colleagues around the globe show that our results are not unique, that this actually works in low and middle income settings. So our conclusions are that resource-oriented psychosocial interventions have generally shown to be beneficial in our context. They appear to share these core experiences like like better confidence, better empowerment, feeling empowered to take an active role in your treatment. Also, in all of three interventions, we noticed that patients really appreciated building their relationships in Dialogue Plus with your clinicians, in multifamily groups with your family members or with your friends, and in volunteer support, building relationships with your volunteers. So this may indicate that through the psychosocial interventions, we can link this humanistic and therapeutical approach. Regarding this second theme, the experience of novelty, this may or may not fade over the time. And also, we concluded that these interventions could potentially reduce the burden on clinicians and health services. And also, wider implementation should be possible. And these sustainability concerns need to be addressed, but we think that they can be addressed. Thank you, everyone.
got time for just one or two questions. I'd like to kick it off.
So this is very question about specificity. I mean, that's three very different steps that they involve giving three large simplified data inputs. And at the end of the time, everyone feels much better than the group where they do get something. But it doesn't change longer that any old site, it doesn't matter what you do, any old site essentially the group where you can get patient advance their self-esteem and instruction. Would have a similar effect, and the problem is there's nothing very specific about any increase.
Well, in our study, we wanted to find out if in their experiences do they point to some common processes. So we think one of those is that they build relationships.
May I reverse your hypothesis? There is something seriously wrong if we don't do anything. Yes. So, and this is showing that we need to do psychosocial services and that they are efficient.
Yeah, like generally treatment as usual in Bosnia and Herzegovina consists of a patient visiting his psychiatrist once in 3 to 6 months, and it's mostly like 10 minutes meeting, and it's just for prescribing your medications. So we think there is a really lack of the psychosocial approach generally to patients in psychiatry.
It's some really interesting results, and I'd definitely like to hold on to some of these comments as we build up the picture. Now we're going to turn to something a little bit different, which is one of perhaps the spin-off projects from Globe. And this is going to be presented by Professor Carlos Gomez Restrepo, who was the PI in Colombia. So I'll hand over to Carlos.
Well, I'm glad to see you. I was, and to meet you, but to see you, really. I will present this art-based participatory project. It's a different one, and I will try to say some things about our country. Here it is, and here in the last one is the Amazonas one, that is the longest river in our world. As Segan told him, and they learned that in Uganda, and I in Colombia I learned that it's the Amazonas, not the Nilo. So we have some fighting things. Here's our country, a very special one with a lot of conflicts. 9 million persons have been displaced in Colombia. We have around 4,000 massacres in 60 years with a lot of people going on and with a lot of problems. Although that in 2050, we got 2% of depression in our country and 5% of anxiety. Although during the pandemic, we get a lot more of depression. And we did this study over there online with some bias, and we get 68% of depression, severe, moderate or severe depression, and 53 anxiety. So we begin to think, what can we do about that? And we begin to think in a new project and an innovative one around how we could build resilience in adolescents to build and to offer them something. So we begin to get a strengthening creative, socio-emotional, and communicative skills to 6 adolescents that were depressed. They were between 14 and 17 years, and we give them some workshops to strengthen that things and tell them to go to the community and see other adolescents and interview them and take a photography about what is resilience for the adolescents and how they did it, the adolescents for the adolescents. And we explore resilience and coping mechanisms in adolescents. So the adolescents leaders are these 6 ones, 3 women and 3 men. They had depression, and we get only 2 were the professors that teach, 1 artist, the middle one, and over there is a young physician of our university that is very interested in mental health and in adolescents. And in adolescents, they made workshops with them. The training was like this. We make the basic technical training about interview skills, photography, visual creation, and creative writing. And then we make a concilium with them, encouraging the expression of emotional and mental health issues through the photos and the text they made. And then they get that type of feedback with the professors. Here is the group. They make really a very good group. We give them, all of them, a photography machine. They have it over there, you see. And then we begin to make the artistic workshops. First, a work plan. Second, a creative writing, photography, audiovisual creation, interviews, how to make interviews, and also the content creation and collective creation. And with that, we tell them to go to their schools and the community and their friends to make the interviews with them. And each of them will make between 10 and 12 and 15 adolescents. So we get a sample of 75 adolescents of Bogota, in whole Bogota, about resilience. In this part, we see resilience, and we try to analyze how they manage the emotions before the pandemic. And during the pandemic, we ask them that questions also to see the impact of the pandemic for them during their life, and the access to emotional support, if they have it or not. And then we make some counseling sessions about recognizing individuality and interest, about the text and photography feedback, in which they receive some feedback about their work, and final self-reflective exercise in which they did a video about the whole experience that I will show you finishing the presentation. The results are these. The first result is this one. It's a book that I have some copies, and I will give to the first 9 persons that come to me. It's in Spanish, and we have here the photographies they made, and also the text they have. We make an artistic exhibition in Bogota and also here in UK with the photograph and the resilience part. And we make a symposium with them, asking about the whole experience. They told us about how they manage the anxiety and depression, and also how the adolescents manage it. Finally, we make the video of the whole part. This is the book. This is the symposium, in which they were the leaders of the symposium, really. And here is the artistic part, in which they give the book to the people that went over there. That were about 200 people over there from schools and universities in UK also. So the conclusions: arts-based participatory methodology can complement mental health education. It also helps adolescents to develop artistic abilities that really are very important now in depression and anxiety, and to deal with stressful situations and emotional distress. And the project helped to develop personal skills, capacities like empathy, ability to listen, validation of others, sense of belonging, etc. Now, I think this is very important, and this is a great methodology to go inside the things, really. And for the conflict area, the topics, we developed that. And I think that we must do it in other parts of conflict. As you know, we have a lot of parts of conflict in our country. We are now developing with the group of UK a study in conflict areas. that will give us some sense of feelings. Okay, here is the video. This is Bogotá, 8 million people or less.
Desde sus inicios, la pandemia por COVID-19 ha puesto a prueba la resiliencia de los adolescentes en Latinoamérica, el Caribe y todo el mundo.
Para muchos adolescentes ha sido un verdadero desafío encontrar un bienestar emocional en medio del encierro, las restricciones locales y el temor al contagio.
Los proyectos participativos basados en las artes invitan a la construcción de resiliencia entre los adolescentes, pues por un lado promueven su bienestar emocional, pero también promueven su empoderamiento frente a la búsqueda de soluciones a problemáticas comunes que afectan a nuestra sociedad.
Sus beneficios promueven la construcción de liderazgo, confianza e identidad en los adolescentes.
Este es un estudio colaborativo entre la Pontificia Universidad Javeriana de Bogotá y la Queen Mary University of London, en el cual se involucró un grupo de 6 adolescentes líderes en salud mental procedentes de Bogotá. Estos adolescentes fueron autores y protagonistas de este gran proyecto.
Cada miembro del equipo, mediante la expresión artística escrita y fotográfica, ha registrado los mecanismos de afrontamiento del estrés emocional de 74 adolescentes colombianos. Sus testimonios son un claro ejemplo de resiliencia y empoderamiento en medio de esta crisis sanitaria que sacudió al mundo.
The arts offer young people an opportunity to express their thoughts and their feelings, and to do so often without using words or discussions. The arts is also a great way for people to learn how to deal with their emotions, and it gives people the opportunity to interact with others who may be experiencing similar problems.
Cómo se relaciona el arte, la salud mental y cómo esto, a través de expresiones artísticas, los adolescentes nos pueden dar claves de qué tipo de resiliencia utilizaron en épocas determinadas, específicamente actualmente durante la pandemia. Vamos a construir conjuntamente con los jóvenes y con el equipo de Inglaterra estrategias que nos sirvan para mejorar la calidad de vida y la salud mental de los adolescentes en Colombia y en Latinoamérica. Okay, that is the project, and thank you very much. Excuse me, I will take a photo to take to my students over there in Colombia. So
one more presentation before we take a short break. So yeah, lovely. So now I'd just like to have the pleasure to introduce Professor Nelson Siwan-Kambo, who was our project principal investigator for Uganda. He's going to be talking about a slightly different study, but one that I think is really exciting and definitely worth mentioning. So over to Professor Nelson.
My presentation is about an educational intervention to enable children to assess claims about benefits and harms of treatments. This study was done in Uganda, which one of the British prime ministers called Uganda a part of Africa. This is a country which is landlocked, surrounded by Kenya, Tanzania, Rwanda, South Sudan, and the Democratic Republic of Congo. What do we mean by treatments in this study and several other studies is anything that we do to improve or maintain our health. And it goes from the well-known injectable medications, vitamins, physical exercise, foodstuffs, and of course, the masks that we've been putting on in recent times. What motivated us to do this study? We know that people are, we know that people are flooded with claims about effects of treatment. And this is not saying anything about this audience here, but we know that people get their evidence, what they claim their evidence, from their peers, from their health providers, or from newspapers, internet, and so forth. We also know from diverse evidence that people's ability to appraise health information is generally poor. So we intended to, in this study, to design learning resources for primary school children, and also evaluate the effectiveness of these learning resources on children's ability to assess the benefits and harms of treatment. Why did we go for children? Children, we thought that if we reach out to children and can successfully teach them about critical thinking, they are a large population and therefore will be a large resource for the country and for the entire world. If you take my country, 50% of the population is below 15 years old. And we also know that children could affect or influence their families and friends. And they are the future leaders, of course, and decision makers. Teaching children critical thinking skills, therefore, can lay a strong foundation for assessing health information, foster desirable dispositions, and hinder uncritical beliefs. We selected 12 key concepts through use of experts that we should teach these children. Here is one example of a key concept, that is, treatments can cause harms as well as benefits. If they appreciate this particular concept, then they will always take seriously any intervention and look for benefits as well as possible harms. We co-developed and co-designed interventions, the learning resources. We co-developed them with the students at that level where we are going to do the study, as well as teachers across the country, education officers, and curriculum developers, of course, with the researchers. Several resources were developed, but the most important are three. That is, first, the teaching textbook for these students, also the students' exercise book in which they will do their work to develop the skills being taught, and the teacher's guide, because the teachers needed it to guide the students. And students, therefore, we expected would be asking the question, what is the basis of a claim that is being thrown around? And also, they would appreciate that fair comparisons are a good way to assess benefits and claims. We assembled about 3,000 schools in central Uganda and ended up, through exclusion criteria for eligibility, we ended up with 120 that accepted to participate in this study. We randomized the 120 and 16 control, another 60 in the intervention. The control continued with the curriculum that the school had, whereas the intervention, in addition to that curriculum, they were taught critical thinking. And at the end of the intervention period, both intervention and control students responded to a claim test. This is an example of a Uganda classroom at that level, which is very overcrowded. We did also process evaluation to assess how the intervention was being delivered. And we did this through interviews and focus group discussions of some teachers. There was a structured classroom observation by research assistants sitting in some lessons to see and hear what was going on. And also the teachers filled in lesson evaluation forms that were looked at. What were the results? The results were most striking. At the end of the day, it was clear that the intervention arm did much better than the control arm, on both primary outcomes. That is the average score as well as the score that was predetermined that will indicate passing of the test. We followed up those students 1 year after the intervention ended. And again, we wanted to see what the retention was like. And it was clear, even at the end of 1 year, that indeed there was retention of the skills that the students had gained. The children loved tremendously, and so the teachers too. They loved this training on critical thinking, and they enjoyed working with the resources that we provided. In conclusion, it is possible to teach primary school children to think critically in schools, and our intervention was effective in teaching these children in a low-income country how to appraise information and make informed health choices. If you want more information, you go to this website, and that gives you a lot on what was going on. But also, our study is one way of promoting the use of evidence to change the world.
Just sort of time for a couple of questions. I think it's really important that this is such an important study. It would be good to hear some people's thoughts and opinions. So time for a few more questions before we go into the break.
Those were maintained for improvement for 1 year. It would be interesting to talk about the maturity of this when sort of adults see, you know, this impacts on like disability tomorrow. How long do you think this impact, this even would be maintained without kind of a topical prevention or kind of form of education in that time before adulthood?
I can't give you a definitive answer as to how long this will be retained. But what we want to do in the future is to continue following up such children for a longer time. In fact, we've embarked on a second study, similar study among older children. These were level 5 children in my country. Level 5, those are 9-year-olds or thereabout. We are now doing a study among the 12 to 15-year-olds, not only in Uganda, but in Kenya and Rwanda, to see whether similar effects can be found in older children as well as a different environment. So after that, we'll be following up children for a longer time.
Got time for one more question.
Could you share some experiences of how reconcile context like evidence-based children? Because as a child, you hear messages from your family and community, and then school, and you say, let's learn how to challenge these, and you have to be very sensitive and share how you approach that.
So as we designed the study, one of the things we were concerned about is that we will turn children into, in quotes, rebellious children, that they will go home and question what their parents are telling them. If they tell them, oh, you have a headache or something, please take this. And they say, what is the evidence? We are very concerned about that. And so, because we co-developed this learning resource together with teachers, with some members of the community and so on, we posed this question. And they said, no, let's go ahead and see what emerges. So part of the work that was going on is to see whether there were any adverse outcomes in implementation of the study. And what you're talking about would have been an adverse outcome, but we did not find adverse outcomes that are in the line you're talking about. And we're emphasizing that even much more in the current study, which is involving older students.
So And what Professor Siwan Kame forgets to say, and he's very modest about this, this was an absolutely stellar Lancet publication that I'd encourage you to check out, and that this has been taken up on about 20 other countries around the world now. So I'd just like to end by asking for everyone to give a big round of applause for Nelson and all our speakers. So we're gonna take a short break now. I'd like to ask people to come back for 10 to 4, where we're gonna have the second half of these fascinating talks. And in the break, I'd encourage you to talk to our speakers, get books from Carlos, get papers from Francois, and really get to know our wonderful speakers. So thank you.
To the second half of this Barts afternoon. Since you are listening so fast, we are trying to finish early. That's the aim. Let's see what extent that works, but we will certainly not overrun and be rather a bit shorter. So we keep going our tour over the world now with a presentation, although presented by someone from South Africa. It is from Bosnia-Herzegovina, Colombia, and Uganda. Francois van Loggerenberg will talk about Dialogue Plus in primary care.
Thanks, Stefan. Hi, so I'm Francois Loggerenberg. I'm going to talk about some work that came out of the initial GLOBE studies, the results of which you've been presented with earlier today. So this was specifically a study to look at using Dialogue Plus in patients with chronic physical conditions in primary care in the 3 original countries. And this is an extension of the setting in which Dialogue Plus has been used. And it was extension work on the original GLOBE project. So the original collaborators with Queen Mary University were, of course, Bosnia-Herzegovina, Colombia, and Uganda. And those countries all did, as you saw earlier this morning, earlier this afternoon, did studies on 3 resource-oriented interventions, psychosocial interventions for serious mental illness. During one of the teaching weeks, the second teaching week in London, the investigators discussed potential research ideas, and they realized that although Dialogue Plus has been extensively tested in mental health settings, there's very little systematic studies on how Dialogue Plus can be used in primary care. And because Dialogue Plus is such a low-cost intervention, making use of existing and ongoing clinical meetings, there is the potential, therefore, that it would be particularly useful in low and middle income countries where there are resource gaps. So the aims of the Dialogue Plus in primary care study were to adapt Dialogue Plus through a process of stakeholder consultation, refine the training materials, and to promote wider uptake and implementation of Dialogue Plus, and then also to explore the feasibility and acceptability and effectiveness of Dialogue Plus for patients with comorbid physical and mental disorders in primary care. In terms of the methods used, exploratory non-controlled trials were done in all 3 countries. At least 30 patients with chronic non-communicable diseases were recruited, and they were given up to 3 Dialogue Plus meetings over the course of approximately 3 months in their routine clinical care. And sometimes the duration was a bit longer due to pandemic restrictions and the difficulty having those face-to-face meetings. In the course of the study, we also collected qualitative and process data, so interviews and focus groups about experiences of using Dialogue Plus in primary care, but also looking at the number of sessions completed as intended, the number of participants recruited and retained. And that would give us a sense of what the acceptability and feasibility of Dialogue Plus would be. To look at the effectiveness, we measured quantitative outcomes at 3 months after the 3 dialogue sessions. In terms of implementation across the countries, in Bosnia-Herzegovina, they were able only to recruit 25 of the participants. One of the participants didn't complete all of the intervention sessions, but all 25 were included in the analysis. In Colombia, 32 participants were enrolled, 2 were lost to follow-up, and 1 withdrew from participation, and so 29 patients are included in the analysis. And in Uganda, they recruited 60 participants at 2 clinics. 54 of those participants were able to provide follow-up data, and so included in the analysis for an overall number of participants of 108. In terms of the different clinical populations, so they were quite different in many ways in each country. Particularly noteworthy in Uganda potentially is a much higher proportion of high blood pressure and diabetes patients, and also older patients. That was the nature of the clinic from which the patients were recruited. So it is quite a broad range of conditions, and in 3 different countries, using one intervention to see how it fares. In terms of the results, so the intervention was delivered as planned within the restrictions that were imposed due to the pandemic. And so we would say that it was successfully implemented. In terms of the acceptability and feasibility, qualitative data from Bosnia-Herzegovina is very encouraging. And what we found was that patients really liked Dialogue Plus as an intervention. What they liked was it structures the conversation they have with the clinician to look holistically at various aspects of their life, something that didn't happen before, so the discussion wasn't happening. It also makes the discussion very patient-centered, because the patient gets to talk about their own satisfaction with all of these aspects of their life. And so it goes beyond just medication, as Hannah was saying earlier, and it goes beyond just care for the physical condition. The patients also felt that it increased a sense of empathy and understanding from the clinician, because the clinician now was actually asking them about various aspects of their life, not necessarily directly related just to the treatment they were receiving. The patients also felt that they could see real improvements in their life, and particularly because, as Stefan pointed out earlier, in Dialogue Plus, you identify various areas of your life that you want to improve your satisfaction with, and you agree concrete actions. And so in that activity, patients could see from meeting to meeting that things were really getting better for them overall. So they really felt a sense of personal improvement. In terms of the quantitative outcomes at 3 months, there was again a statistically significant improvement in subjective quality of life, symptoms of anxiety and depression, but an improvement, but not a statistically significant one, in objective social situation. And again, as has been mentioned in the other talks, the effect sizes are very large, much larger than we would see in trials in the UK, for example. And so these are very important and significant improvements. So the conclusion then about Dialogue Plus in primary care is that it can be used, it can be implemented and used successfully. The sessions were mostly completed as planned. The patients were very positive about the experience of using Dialogue Plus. There were overall very significant improvements in the quantitative outcomes with some very large effect sizes. Again, I think for the reasons that have been mentioned in the other talks. And so Dialogue Plus does appear to be an attractive option for use in primary care, given that it is such a low cost, very flexible, and has been seen to be effective in so many different settings. And I think the main lesson from this is just we need to approach our patients differently and have these conversations differently. It's not just about physical care, but also about other aspects of a life satisfaction. Thank you.
Yeah, thank you very much. Is it working? Consulting. So, thank you very much. I think we have got 1 or 2 minutes for questions. Any questions? Yes, please.
Hi, Prof. I wondered if you mentioned earlier that mental health is job situation with the domain that we talked about most. So I wondered if that was the same.
We haven't yet looked at the Mensa scale. Sorry, it's on the list. Thanks to you.
I was wondering, in terms of recruiting participants, you mentioned that in Uganda specifically, you got more kind of older because of the that was being recruited from. Is that something that is going to be utilized in the future studies or next steps?
So I think the point about the way in which the clinics were selected was that there was a diversity of environments to see whether it would work across different clinical populations. And it seems to be feasible and acceptable and doable. So yeah, we probably would keep that aspect of clinic selection in future research.
Studies, whether you agree or what your take is on all these interventions, just like interventions to kind of improve mental health problems. Maybe it's just the absence. Like all these things should be part of life. We should have like high quality interactions with people that would go focus or intervention. people spending time with us without some of those.
Yeah, so I think that's true. I think that's true in all of the intervention that we've done in all of the settings. Somebody was saying it's like rain on dry ground because there really isn't anything. So when you do something, it makes a huge improvement. And I think this, particularly in primary care, shows because mental health and social well-being is often just neglected in physical health and the treatment of chronic conditions, there's a real opportunity to just change the conversation and to change the focus slightly in those clinical meetings. And you could really impact on not only quality of life, but undiagnosed and unrecognized mental health problems. So I think that's a very exciting opportunity going forward.
Is there a GP here? No, because I would just wonder when we say low resource setting, whether a GP in the UK today would think, oh, that must be other countries. So I'm not sure whether that applies here to the absolute same extent. Okay, thank you very much again. Now we are moving across to a completely different continent, to Argentina, and Dr. Natividad Unvar will talk about Dialogue Plus in patients with anxiety disorders and the pure remote delivery.
Thank you, Stefan. Hello, everyone. Well, before I start talking about what we did in Argentina, please let me tell you something or a little bit about my country. Argentina is a large country in the southern of South America. It's almost known because it's beautiful and a stunning landscape. For example, we have in the northeast, the rainfalls of Iguazu. In the southeast, we can find Puerto Madryn and Peninsula de Valdés, where there is a lot of animal variety, such as whales, seals, and penguins. In the deep south, we have Ushuaia, that is known as the end of the world. And in the west, we have the Andes Mountains that also from the north to the south, it changes its landscape. In the north, it has more desert, such as the Moon Valley in San Juan or the Salinas in Salta. In the middle, we have Mendoza and the Cuyo region with its beautiful vineyards. And if you go there, you can taste a couple of Malbec wine. And in the south, we have the glacier parks with the Perito Moreno and Bariloche, the famous ski center. But also you can know, because our famous figures, people that is known all over the world, such as the football players as Maradona or Messi, some political figures such as Ernesto Che Guevara, the revolutionary man, or even Evita Duarte de Perón, the first women that took political actions in our country, and now the Pope, Francisca. I live in Buenos Aires, that also has its own attraction, that is tango. Tango can be sung as Carlos Gardel did, or can be played or composed as Astor Piazzolla did, and also it can be danced. In the middle of the city, there is the place where I work. There is the School of Medicine of the University of Buenos Aires, where I teach, where we have almost around 10 careers, between careers and leisures, where we have, until the last year ends, most of 41,000 students that they came from all Latin America and some from Germany, Oslo, and Italy. That is the picture from the above. And in the top. And above, we have the clinical hospital. That is where I do my clinical practitioner. That is one of the 3 university hospitals, and where the patient from the study came from. So for this study, we decided to focus on patients with anxiety disorder because it has a global prevalence of 3.6%. It has been ranked 6th cause of disability. And of course, it has a negative impact in life, in studies outcomes, in economic situation, in relationships, and in social functioning. I think that the relevance of this study is that is the first Dialogue Plus that is testing in remotely form. and with patients with anxiety disorder. The structure of the study is almost the same that all you have already heard. It takes almost 6 months. It has an interview as a baseline and an interview at the end of the study, and 4 interventions. But the reach of this is that we can do it through Zoom meetings with all clinicians who received first the training and then established the interventions with participants. One of the things that we found like a challenge was to identify patients with anxiety disorders. So for that, we screened 125 patients, and then we have to remove all that patient that has anxiety symptoms, but we're going with another condition, such as mild cognitive impairment, neurodegenerative disease, personal disorders, or even psychosis. After that, we have a group of 61 patients that when we took them the quality of life scale, the MANSA scale, we would score more than 5 points. So almost they drop off the study. And that gives us a group of 44 patients, which diagnoses were social anxiety disorder, panic disorder, generalized anxiety disorder, and anxiety disorder unspecified. Our results were that we found a large effect and a positive effect in the quality of life and the social outcomes, and where patients improved their quality of life, and we found that the psychiatric symptoms decrease. Also, when the study ends after the 6 months, we conduct 15 interviews to know what people thought about the using of dialogue. We found that most patients reported positive experiences. Most of them like to use dialogue. Most of them don't want to stop using dialogue. Some of them make positive changing in her life. In this case, we have the case that a woman that suffer from panic disorder, she has had divorce 10 years ago, but she couldn't separately physically from his husband. She needs that his husband stay at home so she can manage her fears. After using dialogue, she can pick up her husband from her home. So she was really very happy. And another positive that we found is that we using during the lockdown in Argentina, that it takes almost 6 months, so people couldn't go to the hospital, and that makes that most of them didn't stop their contact with a professional of mental health. As a conclusion, we found that dialogue can be used as a remote, in remote form, not only on presence, and we have effectiveness results with patients with anxiety disorders. And that picture is my team on my right. In the picture of my right is the PI, that is Ignacio Brusco, that he wouldn't came. And on the left is Fernando Carbonetti, that is also a researcher in Buenos Aires. Thank you.
So, any questions? Yes, please.
I wonder if dialogue classification used kind of integrated together. Did they have to make any changes to how they did dialogue class, or how?
No, we use almost a tablet. What we did, that's why we use the Zoom platform. We share a screen with participants. We connect Zoom in the tablet and add the Zoom through the cell phone or through the computer with the clinician that was taking the study. And then, well, the participant in his or her home. And they will try, like, they just try to touch the screen of their own mobile phone or computer, whatever the patient has, and saying aloud. So the clinician by his side and with the tablet was just selecting the responses.
There was some way for the service user or the patient to also complete the scale. So for the shared screen to be going the other way, with the clinician giving the changes.
I don't understand.
Whether it would be helpful to patient to also be active.
Yeah, I suppose, but we have to prove. The idea now is to test dialogue in presence with patients that now come back to the hospital and see what happened. Yes, we have. I didn't put it. They also liked to use it. This tool was used from psychiatry residents, by psychiatry residents and psychologists. And they help to get shorter their interviews that maybe they don't organize well and it takes 45 or 50 minutes. With dialogue, they only use 30 or 40 minutes. So that's helpful.
I can explain the background to Nadia's question is that she's working on a project to develop a specific remote dialogue plus version. Then it will all be more elegant. But I think it's very encouraging because it works anyway. Any other question? Otherwise, so thank you very much.
Okay, thank you.
Well, now, Francisco Diaz, I have to look up the name Canseco because everyone calls him Pancho. He's not been able to come. Again, up until the last day, he was sitting with his suitcase packed, then had to unpack it. But he sent a film, a very, very brief one about a project that I think is absolutely heartwarming. So off we go.
Yes.
The Flute Theatre from London came to be working with La Plaza Theatre in Lima to explore ways in which theatre could reach people with autism who are experiencing severe isolation during the pandemic. What can theatre do in a crisis?
Hola, Adrián. Hola, Pau. ¿Tu turno?
Sí.
Hola. Muy bien. Hola, Adrián. Hola, Pau.
On the island of Zoom, with Shakespeare as their guide and a shared passion for creating rich, meaningful experiences in theatre, Flute and La Plaza offer insights into autistic people's experiences through the pandemic and reveal what we will need to do to build a brave new world of disability inclusive recovery.
Shakespeare's words, he says, at the first sight, they've changed eyes. And what that means to me is that you can see the world through someone else's eyes. I now have your eyes and you have mine. I understand the world from where you are. And I think that's what happened, that connection of way over on the other side of the world.
Bien jugado, Ariana. Ahora juega conmigo. Vamos a buscar a Fernanda con los ojos.
Flute nos transfiere su metodología Hunter-Harvey. Nosotras desde la plaza y desde Perú compartimos nuestra cultura.
Y las personas autistas sus experiencias. Aún así, existiendo la pandemia, así aún haya este distanciamiento, la virtualidad nos permite encontrarnos para poder crear un proceso artístico, ¿no? A través del teatro.
Buscamos a Miranda con los ojos. Vamos, Sergio. La, 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 la. Muy bien. ¿Y hacemos?
No se trata de contar la historia de la obra de Shakespeare, es coger su esencia para guiar al participante por un viaje emocional y sensorial.
momento estamos en una montaña y en el otro en el fondo del mar. Shakespeare nos permite eso, experimentar la intensidad de la vida y estar lejos.
¡Ah, Calibán!
¡Aldo! ¡Nos han descubierto!
¡Gira!
¡Giramos, Aldo! ¡Una vuelta! ¡Dos vueltas! ¡Última! ¡Oh!
No es posible hacer este proyecto sin ellos, sin ellas. Cada juego está creado en base a sus necesidades, a su disfrute.
Acércate, sopla. Oh, muy bien, Camilo, muy bien. Y ahora flotamos sobre las nubes. Muy bien, Camilo.
El juego es el lugar donde se experimenta la vida. Y el juego teatral permite que los participantes puedan afrontar situaciones que les son difíciles en su día a día.
Ha sido un gusto de actuarnos. La función debe continuar. La función continúa y el telón se abre nuevamente sus puertas.
Nuestros hijos tienen una forma de hacer las cosas diferente. Más allá de los títulos o lo que te digan los médicos, es tu hija, ¿no? Es tu hijo. Y tienes que darle herramientas para que salga adelante.
Además, queremos seguir contactándonos con las asociaciones y colectivos de personas autistas, sus familiares, generar lazos con entidades del Estado, con instituciones educativas, trabajar juntas para el desarrollo y la difusión de nuestro proyecto.
Póngase de pie. Aldo, Andrés, vamos a girar. ¿Listos? Brazos arriba.
Toma mi mano y mi corazón, la 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 la. Toma mi mano y mi corazón, la 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 la. Toma mi mano y mi corazón, la 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 la. Toma mi mano y mi corazón, la 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 la. Toma mi mano y mi corazón, la 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 la. Toma mi mano y mi corazón, la 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 la. La 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 la. La 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 la.
Oh, muy bien, Joana, bien hecho. Ahora acércate. Andrés, toma asiento. Muchas gracias.
Adiós, Pedro. Adiós, Ariana. Adiós, Aldo. Adiós, Camilo. Adiós, Juan Carlos. Adiós, Joana. Adiós, Jerry. Adiós, Sergio. Adiós, Adrián. Adiós, todos. Adiós. Adiós.
With the subject of theater, now again move to a different continent, to Pakistan, and theater by people with psychosis for community engagement. Dr. Mehek Ali will tell us about her experiences.
Okay, hi everyone. Of course, I'm tasked with ending today's session after this fantastic video, so good luck to me. All right, so I work at IRD. IRD is a global health delivery and research organization. We have a presence in 15 countries and country offices in 6. So I'll be focusing on Pakistan, but just to give you an overview, we do work in maternal and child health, mental health, non-communicable diseases, infectious diseases, etc. But I'll come into Pakistan. So I live in Karachi. Some of you might have heard of Karachi. It's supposed to be one of the most dangerous places to live. So it has some of the poorest outcomes and highest crime rates in the world. But it's also known as the City of Lights. Interestingly, that is actually a reference from a song where the artist is actually saying that Karachi is a seedy city where things happen at night, but that's why the lights are always on. So in true Karachi fashion, we have reclaimed that title and made it something positive. So we are, with lots of love, the City of Lights. And one of the sayings that you'd see in our city is Karachi dekh magar pyar se, which essentially means look at us, but with love and compassion. So the purpose of showing you this picture is to show that the city is highly congested. It's a densely populated area. There's a huge saturation of services, not great quality services, but they do exist. But not all of Pakistan looks this way. Rather than showing you all the beautiful touristy pictures of Pakistan, which by the way, you can find on a lot of adventure and nature magazines because it's a top destination for adventurers, I want to show you what Pakistan looks like for the communities that we seek to serve. These are usually rural community members living all across the country. And as you can see from this picture in Larkana, these are usually communities that have limited access to infrastructure. They have limited access to education, health, and other utilities and services that are essential for well-being and living. But this also means that as a result, IRD does a lot of outreach work, which means we can't sit in an office or sit in a clinic. We need to be out in the field. We need to be with the people that we're seeking to serve. So keeping this in mind, in order to engage this population, we have to be very intentional. So we use a lot of community engagement mechanisms. One of these is the use of community groups, where we take a socio-ecological model. So we ensure that we have people who have lived experiences, their families and caregivers, and the larger community to which they belong. We use interactive health education sessions and a novel interactive theater of the oppressed approach, which I'll go into in a little bit. And we amplify this with health communications using below the line activations, interactive social media, and mass communications, which could include things like television, radio, SMS, vehicle branding, etc. But for the purposes of today's talk, I'll only be talking about Theater of the Oppressed. So Theater of the Oppressed is a interactive forum theater style inspired by Paulo Freire's pedagogy of the oppressed. And it was designed by Augusto Boal, who is a Brazilian theater maker. Now you might be thinking, how does a Brazilian theater concept fit into Pakistan? But actually Pakistan, being part of South Asia, has a huge history of cultural expression using theater, storytelling, and images. So it fits very nicely in our context as well. So this is an approach in which you break the fourth wall for the audience and you invite them to step into the play, take on the role of an actor or of a character, and take and steer the conversation and performance forward. So it's very agentic. It requires a lot of critical consciousness raising. And so this way it serves for people who are it showcases a scenario of oppression, which allows people to identify systems of injustices, helps them to ask critical questions about it, and then drive solutions that are appropriate in their context rather than being given to them. So this is why we think Theater of the Oppressed might be a really interesting methodology to use in our work. And so far we've used this across 3 programs, and I'll be giving you examples of each of these. So in the first example I want to showcase, in April 2019, Pakistan faced its 8th HIV epidemic, this time concentrated in the town of Ratodero in district Larkana, which was the picture that I showed you earlier. In this epidemic, 1,100 children were diagnosed with HIV, largely attributed to medical malpractice. You might have seen its coverage in the New York Times and other articles. But what we really saw from here is that there is a lot of multifarious marginalization for people with lived experiences of HIV. And we saw a huge emergence of discriminatory behaviors for people as well as children and their families who were living with HIV. So when we went in, we wanted to design a project that builds collective action for addressing HIV stigma and creating support for people living with HIV. So especially for this, one of the mechanisms that we used was Theater of the Oppressed. And what we saw was that by having people with lived experiences of HIV tell their own stories in a theatrical form, you're able to have important conversations where people could share their lived experiences and provide solutions that actually fit their context. So some of the kind of solutions that community members came up with were around having social and financial support for people that were affected by HIV, providing nutritional supplements, improving counseling services for people who are living with HIV. And these were all innovations and ideas that came from the community themselves. So hugely powerful in a society where you have ostracized and removed people who have this disease. So considering that we tried this out in a rural setting, we were curious to see if it would work in an urban setting. So in the midst of the pandemic in Pakistan, a lot of endemic misinformation, conspiracy theories, lack of access to services is a major hindrance for vaccine confidence. And as a result of very strict vaccine mandates, we saw that people actually started to distrust vaccines generally. And we also saw a lot of cases of fake vaccination cards emerging. So we created a social media project called Jilo Dobara. Jilo Dobara basically means to live life again. And it wasn't enough for us to just base this online. We needed to do something on ground. And so what we did on ground were a number of things, one of which, again, was Theater of the Oppressed. Again, people were able to showcase their own stories of how they were affected during the COVID-19 pandemic. And a lot of those real life experiences were presented and performed by people who have had COVID or who have lost loved ones to COVID. And again, what we saw from that was that not only was it an important avenue for people to start considering where they're getting information from, having a critical dialogue with one another, but an uptake in vaccine services. That was a big win for this project. And secondly, we saw that it offered an opportunity for intergenerational conversation, particularly between older people and younger people, where younger people historically have not had a lot of decision-making autonomy. And they were often the ones who were questioning their parents, like, why are you believing this thing that someone has forwarded on WhatsApp? It's not real. And parents saying, be quiet, I know what's right. So here we saw that being flipped and questioned. So really shows that agentic ability of Theater of the Oppressed, which helps us recognize our own biases. So we know that this has been a really effective model now for 2 disease areas. But we were really wondering how it would work in an urban setting for something that has a lot of historical stigma as well. So we know that, as Vicky had mentioned for Pakistan, that Pakistan gets a sliver of funding for mental health. As a result of which there is very few resources for people with lived experiences of psychosis or other severe mental illnesses to be in the public sphere, or even have representation amongst their families. They're often hidden away even in the family. So we wanted to see if we could use Theater of the Oppressed amongst this population to create information or build awareness raising around this and get people to start thinking about how to include people who have psychosis in health programming and treatment provision. So we are doing this currently as part of the Pieces project, which Vicky has briefly introduced as well. In this project, we're looking at community-based care in Pakistan and India. And one of the things that we're doing for this, for the first time, is to build a theater company that will have people with psychosis in it. So this group is going to have people who have psychosis, their caregivers, community allies, health practitioners, like mental health practitioners, and trained professional theater actors. And the idea is that this theater company will become a sustainable avenue to continue to generate awareness for psychosis and other mental health illnesses, to stimulate conversation around introducing different types of therapies for mental health, as well as to encourage inclusion and social inclusion of people with psychosis. So we are right now just launching this initiative, and from our early workshops and community experiences and performances, we've seen that people with psychosis take a really active role in writing the script, in building the performance, and conducting it in communities. And community members who are viewing this performance are actually getting to see how people with psychosis want to be cared for, which means that people with psychosis are not only articulating how they feel, but also what they want. And this was very revealing for their carers as well as clinicians who have been part of our workshops. So this is something that we want to continue to explore. I don't know why the format is like that. It was fine when I had made it, but we want to test this in 3 different settings. The first being communities, so that we can use theater as of the oppressed as a way to build awareness around severe mental illnesses in the areas where people with psychosis live. The second is with medical students who are at the cusp of making a really important decision about if they want to continue to study psychiatry and psychological sciences. And the third is with mental health practitioners in order to stimulate them to consider other forms of therapies that could be beneficial to patients and clients, as well as to ensure that their clients are part of those decisions that have to be made rather than just being told what to do and being given medication. So what we expect and what we have seen from our experience is that theater of the oppressed is highly adaptive. And it can be used for multiple geographical scopes, but also can be used in a number of disease areas, meaning that it is a disease agnostic approach. And as a result of doing co-creation with communities, it's a way to ensure that any health program is including people with lived experiences in their tool development, program protocols, as well as future publications and community engagement, which is imperative for dignity and respectful inclusion. And I suppose like the biggest thing that I have a takeaway from this is that what we've seen with theater of the oppressed through HIV, vaccine confidence, and early findings from the psychosis project is that it ensures social cohesion, which is very imperative for collectivist cultures, which are based on shared relationships. And in an issue or in scenarios where you're seeing ostracization and removal of those relationships, those people are actually losing essential resources for improving their health outcomes. So I would highly encourage any of you who and other researchers in health and other social sectors to consider incorporating theater of the oppressed or other participatory arts performances that have been showcased today in your program. And that's it. Thank you.
Yeah.
So the places that we have actually done this in, they didn't have an active theater troupe or company that existed, but historically and culturally, theater is something that's always been a part of South Asian culture. As a result, as you might see in the news of over-Islamization, there's been a limitation on how much that is expressed, but that doesn't change the fact that that's still a very deep part of people's culture. So there is a celebration, even if it's not explicitly seen in communities. So when we went in, it was some of the first stuff we were doing, but it was alluding to a history of performance and arts. So I hope that answered your question.
One of the loaded questions is sort of involved in the thesis project. I just wondered from your experience of running some of the workshops with people with lived experience and their caregivers, has anything really surprised you? Has there been sort of insight that you weren't expecting?
I mean, one is many, there are a lot, but I think one that we experienced very recently was while we were conducting the training for this theater company, just the way that people with psychosis are able to view the world, oftentimes that's not something we see articulated. So especially in Pakistan, I should say. So one of the things that I think was really insightful for us was when we had one of our theater company members explain the idea of understanding what psychosis is as like a lifting of the veil. And like those were his words, that he said, like, it's like my veil has lifted and I can see and there's light. And I can just imagine that as something that could be represented so beautifully artistically, but often in our settings, no clinician is really asking you, you know, what do you feel now that you know that this is your diagnosis? So I think in our setting, it's really those things that are very revealing.
Gender and the relationship
Yeah, super important. So in all the settings that so far we have done theater of the oppressed, it has been gender segregated. In rural settings, this is almost inevitable. You cannot really do performances together. So you will have, you won't have mixed gender performances. But for the vaccine confidence one, which was in Karachi, we were able to do this in a couple of scenarios, but the theater company for pieces is the first one that is going to be a mixed gender group. And so far we've seen really positive reception of that, which also suggests that the intersectionality is something that I think the group is going to start to unfold and learn themselves, which will be really exciting to see how they overcome those challenges.
fine question. One sees you here, you are engaging and energetic, and I don't feel it difficult to imagine that we would be able to engage with you. So to what extent is it a method, or to what extent do you need to find the right people?
I think it is definitely about finding the right people, but I would say that's true of most, yeah, most cases. I think for example, I don't conduct a lot of the theater workshops. We have really fantastic teams who do it. So again, I think it is about who has that intrinsic motivation to want to do this kind of work, and then is willing to kind of shed their own biases and get loose. So that's what you have to do for theater. It's a very visceral activity. And I would encourage all of you to get visceral right now as well, if you want to. So, okay.
So the title for this was from Global Mental Health Reverse, What Can We Learn from Others? And Vicky will now summarize what we have learned, what she has learned.
Thank you. So as Stefan mentioned, I'm going to try and summarize what effectively has been 5 years in about 5 minutes, because I'm very conscious that I'm standing in the way of the pub at this moment. So I want to start by thinking about this as a range of different questions. And the first one, I think we really need to focus on is what we've achieved. Sometimes we don't take a step back. We look so much at the results, but we don't actually think about, well, what have we achieved as a group? So this is what we initially planned to do. So thinking back to what Stefan originally said, that we originally planned to do 9 quite small scale open non-controlled studies. And I'm really pleased to say that this has been mission well and truly accomplished. So what have we actually achieved in that time? In that time, we have done 5 randomized controlled trials. We've done 2 open controlled trials and no less than 8 open non-controlled trials. And originally we planned to involve 270 patients with mental health problems. We took that target and we smashed it. We ended up with 931 people with severe and common mental health problems included across 4 different continents. And this doesn't even include the staff members who took part, the carers and the family members who also took part. And I think that's a real testament to the strength of the research team, not only their commitment, but the links that they have with clinical services on the ground in each country. We've published 12 papers. I can say that again, 12 papers from the group. And in each of those 12 papers, it's been an author from the low and middle income country that has led and has really driven the work. And where possible, we've really tried to promote junior researchers in getting involved in publications and authoring publications. And we have another 5 that are currently under submission and 9 in preparation. And we've also had a successful PhD candidate who completed her Viva only last month. And we've also applied for and been awarded 8 new grants that have come from a range of different funders. And this is to further the work and to further the collaboration, particularly focusing on community-based methods and arts-based methods. And I hope that in the years to come, we'll be up here with very familiar faces presenting on the progress of these studies. So the second question, and perhaps key, is, well, what have we actually learned from all of this? And I think really taking that idea of lower resource setting and resource-oriented interventions, there are a few common themes that we can hopefully conclude. And the first is that they're feasible. We've seen great enthusiasm, but also that enthusiasm has been matched by action on the ground. We've been able to complete all of these studies bar one. And that's at a time when we were challenged by the COVID pandemic, as well as other challenges such as funding cuts. We know that the government cut many of the grants in this area. However, that's not to say that implementation has always been easy. And moving forward, I think we now need to turn our attention to how we can work with local communities, local services, to ensure that the results here are implemented and taken further. We can say that resource-oriented interventions are acceptable. And that's from the perspective of patients, of their carers, and also of the clinicians, but also of policymakers, of people up in government. We're starting to get some real movement and momentum behind the idea of resource-oriented interventions.
they're also highly, highly effective. Something that was touched upon earlier, that when we talk about effects, I used to work for NICE. I used to do some of the reviews for guidelines such as the schizophrenia guideline and the depression guideline. And we used to get excited when we got an effect size of 0.25. In fact, most of our guidelines are based on effect sizes of 0.25. Yet here we're talking about effect sizes greater than 1, and in some cases greater than 2. And when you look at these results, our first thought when the statistics came through, and this is no offense to our partners, was seriously, something gone wrong here. We almost didn't believe the effects, but then time and time again after each result, we were getting similar effects. And that wasn't just on one outcome, it was across different outcomes. And we can speculate on those reasons why, but we know from the work of Hannah and the team in Bosnia about some of those common effects, such as empowerment of patients, people finally feeling like they've got a voice and being given a voice in their own treatment, but also, particularly as we heard in Uganda, within their own community as well. And we also know about the relationships that have been formed, again within services, but also within families and within communities. And all of these, on top of the non-specific factors, have led to some very large effect sizes, and something that we'd like to obviously explore further. But however, it must be noted that there is some variation between the different approaches. And this is particularly in the case of taking this forward in implementation. We know that Dialogue Plus has great potential to be effective, but we also know that it does rely on some technological input. We need to be spending money in services to ensure that it's set up. And we have a new advancement in terms of a progressive web application that will hopefully overcome some of these limitations. We know that family support groups, out of all of the interventions, were perhaps the easiest to implement and set up, whereas other interventions needed some kind of resource to set them up. Families, we just needed a room to meet. And then the families and people with psychosis were very much the drivers of the intervention. And finally, we know that volunteering was really effective, particularly around things such as income generation, which is something that we perhaps don't see so much in high income countries, whether it's through bureaucracy or through other reasons. But where volunteering really had an impact was where it could produce meaningful activities. However, this must be balanced with the idea that volunteering, on the sound of it, sounds like it's going to be cheap, almost free, but actually out of all the interventions, volunteering was perhaps the hardest to coordinate and needed the most input. So now this is something that we'd like to take further to understand how we can turn what on the face of it is a really effective and engaging intervention into something that's feasible and can be upscaled across different areas. Another question we can ask is, well, did we actually meet the expectations? When we started this project, we asked all of the researchers and all of the team what they hoped to get out of this and what they thought they would get out of it. And then we followed up the same people and other members of the team to actually find out about those experiences. And on the whole, we found that generally we met or exceeded those expectations. And that was around the commitment to the research, the being able to get involved in different research opportunities, having a transparent communication. It's one of the things that I've really enjoyed working with this group, is just how the group has clicked and got on, and how we are able to come together from very different backgrounds, from very different places, and work together as a team and as a group, not just as individual countries. But that's not to say that we did well in all areas. There's still room for improvement. And a lot of this, I think, relates to some of the nature of the funding. It's very hard to promote that idea of equal power dynamics when the funding is being given to one institution with a set of conditions and rules, such as forms that need filling in, certain conditions, certain ways of working. And I think until we can look at perhaps a more global way of funding, or ensuring that the partner countries are the leads in receiving the funds, I think there's always going to be this potential for a power imbalance. And it's the same with innovation and mutual learning. And in terms of strengthening research capacity, we made great gains in strengthening the research capacity within our institutions, and particularly of our junior researchers. It's one of the things we are most proud of, our junior researchers. However, this must be taken in a wider context. It's very hard to capitalize on those gains in a system which doesn't support it. So unless we have that infrastructure, unless we can strengthen the infrastructure in the particular institutes that we're working with, we can create fantastic individuals, but we need to be able to put them in an infrastructure which can support their further career development. But on the whole, we would say that this has been a truly fantastic experience, and one that we're pleased to say has met our expectations. I think it's fair to say that we're wanting to go places next. So we have a range of new projects that have come out of the collaboration, and we hope that this is just the start point. Just mentioned a few of the ongoing studies we have here going on at the moment. You'll notice a lot of them are looking at this idea of art and community-based resources, and it's something that we're very keen to explore. And really, just to conclude, I think it's fair to say that for all of us, it's been a journey. And this is just a chance to get the photo album out, if I'm honest. So it's meant that we've had some fantastic workshops with different members, and we've done this in different countries and in different settings. And this has ranged from workshops with the community to clinicians to workshops with researchers where we've sat there with pens and paper and we've scribbled out the designs of studies. We've also made new friends along the way, particularly with our arts organisations. This is a photo from Argentina when one of the new studies, Ola, which was came out of the collaboration, particularly in Latin America, met with a lot of the artists who have been, we heard about, for example, from Pancho's study about the theatre. And this is an ongoing relationship, and these are new friends that we want to take on this next journey. Perhaps most relevant to where we're going next is we've really been able to sample the local delicacies in each of the countries. And we make it a real point that wherever we go, we try to at least trial some of the culture. So these were just, this was myself and Kat. I asked Kat for some photos of what would represent her journey. And between us, this is what we came back with. So without further ado, I'd like you just to raise a glass, most people have cups, to all of the partners in this project, because it really has been a truly wonderful global experience. And before I hand back to Stefan, I would like to send my heartwarm thanks to all of our collaborators. Thank you.